Good morning, everybody. First of all, I want to thank the organizing committee and especially my friend Jean-Claude de Mauroy to give me the honor to speak in front of you. And you know, first evidence, spine is made of hard tissue and soft tissue. We know very well growth, maturation, aging, biomechanics of the bone. But about the soft tissue, we don't know so much. Maturation. You have heard last few days this soft tissue tensegrity. What you know what is tensegrity? Tension giving stability. But in physiology, what is it? It is energy restitution, energy release of this wide structure around the spine. Second evidence, erect posture is necessary. We don't know idiopathic scoliosis in quadrupeds. And you know that long time ago I did experiments on chickens and I continue. And now we know very well some scoliosis deformity in fish. Why? Because fish in the water has the same balance. She has only one swimming bladder. Same balance as a human in the air. And this is an important concept. And you know that long time ago, we did experiments on the pinealectomy. We measure the evoked potential right to left in the brain of these spinal chickens. And the last work we did with my friend Misafumi Mashida on the congenital melatonin deficiency mouse, we know that if they became quadrupedal, never develop scoliosis, but if we put them bipedal, yes, develop scoliosis, but if we give them melatonin, no more scoliosis. And we look in the brain what was happening, and it was all this paraventricular nucleus of the thalamus where all the way of proprioception, balance, cerebellum comes through this. So, in my mind, most modern research about pathogenesis are conversion towards central nervous system. And the last word of René Castellin from Utrecht demonstrates very well that asymmetrical growth of the vertebra is not primary but secondary to axial rotation phenomenon. So third evidence, rotation on the horizontal plane is of primary importance. And this is known from a long time ago. And you see that the horizontal plane was already there from many centuries, I can say, yes. And before the era, of course, you see all these very nice works that were done everywhere, and demonstrating that the human being in the 3 dimension and the horizontal plane, of course, was still there. And the Adams book, I encourage people to reread the Adams book because the horizontal plane was a very good place in any pages of this book. And if you look precisely on this book, you see that the rotatory dislocation junctional mechanism, it's absolutely explained in the specimen. You see very well that for this view from the top, nothing new. If you do with modern X-ray and piling up, we have exactly the same remark. So you remember that in the past, even the French people remember, that René Perriol called one day about specific rotation. And you see very well what it was meaning. It was this rotation at the junction, and you see very often between the shoulder level and the thoracic level. And this is horizontal plane demonstration. And for the people, especially aging people, you see very well that the rotatory dislocation phenomenon is very clear. And when you see on one X-ray the opposite side widening on one side, and you can predict 100% that this will go to this junctional metabosis because of the gravity and the torsion. And Lewis Serre said and demonstrate on this modeling, when you have a complete spine with each vertebra attached on the frame with horizontal stretch elastic band attached to the spinous process, and is the center of the spinal canal, because the center of spinal canal is the center of rotation of each element of the spine. This is clear. To protect the spinal cord, this is evident. We have a discussion with biomechanical, but when we think a little bit, you know that the center is to protect the spinal cord, of course. And when this Lewis Serre experiment was using a node with a flexible brass rod, and when he was pushing this flexible brass rod that was put in the middle of the spinal canal, when he was pushing, he was creating a scoliosis. And because of the horizontal forces that giving the torsional effect, when he was pulling on it, it was reducing the torsional effect. And now, to the application, you have seen, when you use a distraction cast, Tanara Donaldson, very, very gentle, with this turnbuckle and viscoelasticity, you see, you can reduce, you look at the case of one of my patients here, you reduce completely both plane, that both plane projection, because AP is a projection, and the sagittal. You reduce it because you detorque if you are slowly. And now, one of my pupils, Lotfi Miladi, is starting to use this principle to make this correction with bipolar, minimal invasive, with self-stretching with time of after a small elongation. He puts this instrument, and you see that the reduction is very clear, obtained many times. And this will be published, I hope, very shortly. And you have heard just before me, the hard brace and Jean-Claude Demora, what he said. He said detorsion is exactly the same principle that is here. Because why the horizontal plane was forgotten plane? Because of the discovery of the X-ray. Because the X-ray show only the shadow. That we say in shiny shadow. Excuse me, my dear French, but it is that we call in France shiny shadow. It's only the shadow of the 3D reality. And you know, when I start to study the paralytic scoliosis, because my mentor Pierre Conneau asked me to check the pelvic obliquity, and when I was comparing the X-ray and my patient, I discovered immediately that the 3 dimension was missing. And when I did my first drawing, you know, the view from the top was there, and the pelvic vertebra concept went there, and pelvic obliquity. It was in 73, this, of course. And this observation was for me very clear. Fundamental idea, 3 dimension, pelvic intercalary bone, and of course, subsequently, the chain of balance and the cone of economy. When you are in a small cone, you don't need muscle to have a good function, because you are well balanced, it is clear. And 3D for scoliosis, before the computer era, many people have spin. And here, I'm very proud to be here in Lyon, because everybody knows that Pierre Stagnara was a very good friend of mine, as well as René Perdriol, who designed the torsiometer. And you see that the 3 dimension were there, but it was projection. And when you look to a right thoracic scoliosis, this demonstrates very well. You have the translation, you have the lordosis, and you have the hump, the horizontal plane. And remember that all this X-ray that gave a lot of information, but they are based mainly on angular measurement, coming from AP view, from time to time lateral, but all depending, it is the projection of the real deformity. And when you have in your mind a specimen, in your hand a specimen, you understand very well that scoliosis is first a deformity occurring on the horizontal plane, I will say each millimeter, probably each cell level of the piling up disc and soft tissue structure, bone, of course, is there. And you know, the hump defines the structural scoliosis, typical horizontal plane deformity. And you know, to convince you about the important, I defined in the past that I call the spinal penetration index. Because in my mind, 4 types of hump. You have the exothoracic, the classical one, but you have the missing one on the opposite side, and you have the endothoracic protrusion of the vertebral body. So it is clear that 3 dimensions are absolutely important. All these pictures are very suggestive, but they have the inconvenience to forget the piling up. And we must mentally dive into the 3D for everything, even lying, sitting, standing. 3D is mandatory. And at the computer era, very early with Henri Graff, that was a resident in Strasbourg when we coming to Paris every Tuesday to my clinic. And Jérôme Eke was an engineer in computer at the Centre Pompidou. And me, we went there and we try with 2 orthogonal X-ray standing to get a simplified model of the vertebra. And you see it was in 78. And you see the scoliotic spine, difference with the normal spine, and the importance of this horizontal piling up with this view from the top that is so important. It was as much important that I present at the Scoliosis Research Society meeting in Chicago in 1980, the prognostic of the infantile scoliosis. And with this view from the top that was so clear to make the distinction in between the ones that will spontaneously resolving, the one that has progressive benign of mean meta, that has a very special shape when it is seen from the top, and the one that is progressive malignant, then this one you cannot correct whatever you do. Same time, I present in 73 in France the crankshaft phenomenon. And you see that is very clear to understand what is the horizontal plane, because you see this fusion, early fusion, posterior, of course, posterior, but on a twisted spine that create exactly this evolution. Everybody says it was pseudarthrosis, something like that. No, 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 it was not. It was when you see from the top what happened, the top view demonstrates that the fusion, the day of fusion, that in black, and you see the continuing growing of the anterior part, it makes torsion, and this was very clear. And when I went to my sabbatical in the year 1987 in the States, I demonstrate on the patient coming from the States that this was not a view of my brain, it was the reality. And this was published immediately after that. But when we try to publish from France, it takes a long time to go to the paper. So, finally, scoliosis, for me, 2 different entities. That's the one that is developmental, that I call ascending scoliosis, started from the childhood, worsening torsion with growth, probably secondary to a genetic asymmetric neuromuscular metabolic disorder. And when you see from the top, it is clear that this problem, it's an horizontal plane deformity. And when you see the de novo appear and develop at the adulthood, what happens? The primum movens there is this degeneration. And it is that I call the discogenic cascade, and I call descending deformity, but on the reality, when you see from the top and in the space the deformity, quite very, very similar. So each scoliotic spine is a succession of torsion and countertorsion, so mandatory to understand the horizontal plane. And when you do the trunk modeling, and you see very well, when you see this trunk, they allow a visual precise 3D analysis. And when you cut this positive mode of a scoliotic deformity according to the neutral lines described by Chono. Chono describes these neutral lines that are oblique like that. And when you rotate each of them, you see evidence that scoliosis deformity, it's an horizontal plane deformity. Orthosists, prosthetic people have understood probably much better than the orthopedic surgeon. Of course, when we do a EDF cast, we try to detort with the straps, with everything, with the hands, and this is of course. And the 3D brace, that was think at the beginning by Gerald Downey. It creates axial corrective force of detorsion and kyphosing effect absolutely occurring in this horizontal plane, mechanically induced by the respiratory function of the patient. And when you see the reconstruction, the first exam, progression of the deformity, and then the correction you try to obtain in the brace, that is this realignment, but in the space, this is really clear. And if you see this small video, you see when the patient is breathing, you see that the carbon fiber twisted exactly that is necessary to produce this correction, active correction, and see from the top exactly what is occurring. You see the reconstruction of the kyphosis. So I think that the good brace must pull instead of push. And this is a challenge that is to be solved by the orthotist people. Scoliosis, torsion, rotation, horizontal plane twisted up. And of course, this it's clear that this helicoidal axis that at the laboratory of Ensam in 1989 we try to visualize like it is there. Horizontal plane is for me the plane of reference of the 3 dimension, not only on one slice given by CT scan. CT scan give only one slice, but the piling up of all this is successive slice is necessary. But of course, CT scan X-ray was a major advance for 3D. But CT scan reconstruction, if it is localized for a child, very localized, okay. But extensive, no. Be careful. Be careful because X-ray are dangerous on children and adolescents. I did recently, December 2016, at the French Academy, this report about this danger, and you see all the people that was working with me, and we demonstrate the big increase of cancer, breast cancer in scoliotic patients, and the recent Danish study, September 2016, you see 5 times more breast and endometrial cancer for scoliosis reviewed 25 years after the end of the exposure. And this work from Australia, that incidence of cancer in adult age multiplied by 162 if only one CT scan of the trunk and the chest and the abdomen in childhood. Well, and this is not a small samples. 18,000 of cases were seen. And of course, leukemia rates, and you see, danger of the X-rays. So, significant low dose radiation. When I met Georges Charpak and the Ensam engineer, of course, I asked them to build a device to be able to represent this horizontal plane, but head to feet. And it was a EOS imaging system, and this gives you very well the piling up of this horizontal plane. And you see here, but we must learn here, when you see it, you are completely lost in to check what is the ejection of the L5 vertebra, L2 vertebra, etc. It's difficult. And of course, but when you see the view from the top or for the bottom, you can see in various directions. You can make the rib cage analysis with EOS imaging. That allow you to measure the lung volume, the capacity and the volume of the chest, and the spinal penetration index, of course, easily. And you can see the thorax detortion with brace or without brace. It is the computer help you to see that. And you see this last work, recent work of Aurélien Courvoisier, you see without brace, with brace, you see that you have a good, from time to time, a flattening of the entire spine and still in balance. And you see on the right that before and after, the brace changed nothing. So you have to say to the orthopedist, the brace you did, throw it away. Tell me another one. And the French Social Security, you have to pay the one, but have not to pay the first one, of course. Yeah, but smile, but it's necessary to do that. And you know, when we describe the rod rotation maneuver on the CD instrumentation, this, if the structure are sufficiently flexible, you can check a good correction technique. And you see here very well what happened only by choosing the good level to put the instrument and rotating this bent rod, you can make the correction, and you see before, after, this realignment that is not so bad. And to simplify, visual, analyze, quantify in 3D spinal deformity, and thanks Jean-Claude, because you show me in your presentation that using the vertebral vector introduced by my pupil Thomas Hilles, we can not only check the curve progression with simplified vision, and you see here very well. But for example, if you take the Lanke-1 group globally, 301 cases, and when you check exactly the positioning seen from the top, you have you can have 3 more subgroups. So I said to my friend Larry Linke, your classification had already lumbar modifier, sagittal modifier. You need an horizontal modifier, of course. In my mind, each patient is different from the other one. It is why I don't like the classification. The classification for me is only a checklist that pushes you to have in your mind everything you have to check for your patient. Of course, it's useful to make plenty of statistics, everything. But in the mind of the surgeon, don't be attached to the classification. Each patient is different, and this shows you this very well. You see, in one glance, with the vector that are inside the computer of the EOS system, you have to ask him, because it is, you can, if you have the EOS system, you have the vector inside. And you can say in one glance what is the alignment, what is the rotation, everything. I like the work that is done in Montreal by Carl-Eric Aubin that Hubert Labelle showed you yesterday very well, and I hope, but it is difficult for me to understand completely because one vertebra, one scoliotic curve cannot be put in one plane. It is made on the plane of maximum deformity. So, but this has a big importance because this pushes the patient to think about this horizontal plane. This measure will be able to predict the evolution. I don't know, perhaps. So, in some we try to find a prognostic for at the first exam on very small curves. And first exam on the EOS system, we try to, with Wafascali and all the engineer of the laboratory of ENSAM to define exactly severity index. And you see they are coming from the horizontal plane data, intervertebral rotation, torsional index, Cobb angle just a little bit. I don't know if we will leave it because Cobb angle for me has no more big interest for the pathogenesis of the torsion. And you see that when this severity index is very below 0.4, at the first exam you can say the scoliosis will not progress. If it is above, it may be progressing. And when you see the top view, I think that when you have understood this view, you will understand that the horizontal plane, the forgotten plane of the orthopedics, is very important. Because when you see the reconstruction from the front, like that, you see not big difference, but when you see from the top, you see evidently that the torsional effect is there. And you can say that the index on the left side was not progressive. I know it was progressive. So why you wait 25 degrees to start the treatment? It's completely crazy. When you have demonstrated that this scoliosis is progressive, you have to treat immediately. Immediately. And you will correct very easily. This is my opinion. And I enjoy your SOSORt because you demonstrate clearly yesterday, today, this morning, that the not invasive optical measurement, and they are based, from my point of view, mainly on the horizontal plane recording. And you demonstrate a good accuracy, even with the ultrasound, to detect the change for progression and the consequence for the future. That is, all this will be used to screening, to make the prognosis, and you will do one X-ray, one EOS imaging, when necessary only, and you will follow, of course, with optical only, without X-ray, of course, ultrasound, etc. This, when something important to put in your mind that the horizontal plane is very important is that what is the horizontal plane? The horizontal plane gives a smooth adaptation of the skeleton regarding gravity and motion, not very documented, a little bit ignored by many orthopedic surgeons, much better understood by orthosis and prosthetic people and rehabilitation people, I'm sure. And everybody knows, perhaps not, that the brother Ducroquet have imagined to look to their patient in a room that was completely covered, the floor, the ceiling, the walls, by mirror. And he was checking the patient walking, and he described the pelvic step, another importance of the pelvic vertebra, with the change between the shoulder. Now you have the computer with all this Vicon system that you can check it, but only by thinking to make walking your patient with a mirror everywhere, you think on the 3 dimension, of course, and the pelvic state is very, very clear to demonstrate this. So the balance of the trunk is not a question of angle, frontal, sagittal, incidence angle, lordosis, kyphosis. It's a question of 3D padding up of the body masses. Regarding the gravity axis, ignorance of this concept explains some failure in extensive spinal surgery based only upon calculation of this projected angle, removing the compensation possibility. And for example, this patient I treated a long time ago. Excuse me to speak about surgery, but I am a surgeon. That's true. So the spine is not straight. but perfectly harmonious. And so if you look on the statistic of the curb angle, it is not so good. Not so good. But if you look to the patient is very happy, even with a long time. So when I start to do the CDI, I was looking for harmony and not looking for the best curb angle. And you see that this reconstruction, at that time, a long time ago, you see, I make molding before the surgery, just after, and a little bit after. And if you look between the mold that is in the middle and the other one, you see that the adaptation come afterward so well. So even a spinal deformity can be harmonious, as for external shape, as for the X-ray. This X-ray is harmonious. She is scoliotic, but harmonious. And it is important. We are too much addicted by the angle. 3D evaluation of segmental mass, moment, are more important than evaluation of the angle and study of the balance of the body. It's important. Volume, density, mass, moment, barycenter. This is important to have in mind, everybody. And EOS imaging and 3D reconstruction external envelope can give you a personalized barycentrometry, and you make comparison between the gravity line, the platform, and you can get many, many things with that. For spinal deformities, for me, the era of the static angle become, in my mind, outdated. It's necessary to consider and reason with mass, volume, moment, movement, a lot of work now and the future for the brain of the young surgeon and engineer. Remember this drawing that I did a long time ago? The most important part is not the fused area when you look to the result of the spine fusion, but the unfused area, left free above and below. And harmony must be the goal. Because, important remark, alignment is static and balance is dynamic. Alignment and balance means stability. Stability means economy. Economy means harmony. And Paul Belug say harmony is the sister of economy. What is? What is? It is stability within the movement. This is balance. Balance is stability within the movement. And remember this very old drawing that I drew in 1983 when at the expansion of the CD instrumentation. Remember that the disc left free are very important, and you see the movement was there in the 3 dimension. Dynamic balance needs always a reserve of motion in each of the 3 directions from the gravity line. And of course, coupling EOS imaging, 3D motion analysis, very good research tool to try to understand this cone of economical balance that I described a long time ago. And now we can check to reach the goal for degenerative spine and to predict the proper timing of surgery. This is an important way to go, but in practical. In practical, all these research tools cannot be used everywhere. And for me, for these people, especially when they are coming elderly a little bit, the functional measurement, I do this with a very simple chronometer. Speed and walking 5 meters straight, forward, backward. 3 stairs, easy to climb and to go down. And the most discriminant, it's speed and ease to squat and get up. I did that for my own experience, and I can tell you that 10 months after 10 months, the chronometer go a little bit more. So, last thing, very important, speed and ease to do a double task. Double stack, speed and walk on the telephone. When you see somebody in the street that walk and take the telephone and stop to walk, you say, the brain of this man is working not so bad, not so good. This is important. So, you see, despite when I treat this patient, 3D harmony, 30 years later, is still there. And he has not a straight spine. And this is important. And you see the mold before and after. It is important. Now, you know, it is the new thing. Screw everywhere. Screw everywhere. And you think that is harmonious? This is the case that was done in my country some months ago. You see that is harmonic? No. A real advantage has not yet demonstrated upon hybrid, but in this surgery, it is not important. So the important word must be emphasized in the orthopedic language to balance with the gold standard Cobb angle. It is harmony. What is harmony? Music is concordant and agreement between the different parts of a tune. Real rule of physics. The contrary is discordance of a sound. Pictorial art, accordance on the arrangement of successive color. Contrary is clashing of color. In reality, it is difficult to classify because subjective, variable, according education, tradition, historical background. It is why little was done to use this pre- and post-op. But we must think about that. What is harmony for shape and movement? Harmony, and I encourage you to look to this book that this man was professor of anatomy at the School of Fine Art in Paris. Harmony of the movement is the right distribution of the mass of the body, cephalic, thoracic, abdominal, pelvic, hanging above the lower limb when moved. And this is an important thing. Subsequently, harmony is observed for small and large size people, smooth and abrupt shape, heavy and light people, well aligned, exceptionally malaligned, but fluid and balanced movement. Harmony for spine requires 3D smooth alignment according weight, height, an acceptable arrangement of successive mass of the body from feet to head, a 3D static balance within the small cone, and a 3D motion within normal, functional, basic performance. We are far from the gold standard Cobb angle when we speak all the time with this Cobb angle. And next decade, for me, the goal, it is harmony, static and dynamic. So, to end, my personal wishes for the future in AIS. First, avoid surgical treatment as much as possible. And when you do the diagnostic early, don't wait this 25. In the past, to do surgery, it was waiting 50 degrees to do surgery. No, even for treatment, when you treat as early as possible, when you have the proof, of course, that it is a progressive one. Avoid amicable the use of X-ray. Subsequently, early detection for genetic predisposition, early marker for progression, prognostination, optical surface recorder, EOS severity index, early horizontal plane and 3D correction with a new brace generation, and you have to think about even if the brace of Jean-Claude de Mauroy is a big improvement in my mind, very big improvement, and why perhaps we will discover something that puts the brain working very well instead of thinking to genetic manipulation. And in case of surgical treatment, maximum reduction is not the optimum, and 3D harmony is the best predictor. But be careful with the computer. Your brain must remain the grid computer. And the last message for the young researcher, everything remains to be done. Shadows are multiple, new horizons are numerous and infinite. And like said my teacher, that you see here, seek after, and you will find it. And this is written in Matthew chapter 6. Thank you very much.